So the next IV anesthetic agent which we will discuss would be ketamine. A very interesting IV anesthetic agent, I would say, right? Ketamine is a phencyclidine derivative, and phencyclidine is called angel dust, and ketamine is kind of safer version of phencyclidine with lesser delirium etc. associated with it. So what exactly is pharmacokinetic and pharmacodynamic of ketamine we will discuss. So ketamine is phencyclidine derivative. Now it has a chiral compound. It has a chiral asymmetric. Chiral means asymmetric carbon, and it is racemic mixture of S and R enantiomer. So it's a chiral compound and is racemic mixture of S and R enantiomer, right? The S enantiomer is 3 to 4 times more potent. Than R isomer, and metabolism of S isomer is also fast. So S has shorter duration and cleared more rapidly. Now routes of administration, I'll tell you, ketamine can be given by many routes. But before that, what is the appearance? It's a transparent liquid. It's a transparent liquid with a pH near about 5.5. So what is the routes of administration? I would not say mode, routes of administration. We can give it IV, we can give it IM, nasal, we can give it rectal or oral, and by all these routes it has an excellent bioavailability, right? So it has a good bioavailability by all this route. By IV route it has, let's say, 93% serum bioavailability, IM route 68%, nasal 25 to 50%, and rectal and oral 16%, right? It is highly lipid soluble and low protein binding drug. So since it is highly lipid soluble, so it has a very fast onset, and low protein, so again it will have a faster onset. So highly lipid soluble and low protein binding. So rapid uptake in the brain. Since it has a rapid uptake in the brain, onset of action is 30 to 60 seconds on IV dose. So 30 to 60 seconds on IV dose. It has a rapid action. Since it is not lipid soluble, it's a highly lipid soluble and not so much protein bounded. So very fast it will pass to the CNS and we will have a very fast effect. Okay. Then metabolism, like most of the IV anesthetic agent, by liver. So metabolism is primarily by liver. In liver by cytoplasmic 450 enzyme. It is demethylated. The demethylation happens. Demethylation to norketamine, which is 1/3 to 1/5 less potent. Okay, and this is excreted by kidney, renal excretion. So it is metabolized renal excretion. Okay. It is metabolized by liver to norketamine, and it is primarily excreted by kidney. Okay. Now, what is the mode of action? Ketamine, the primary site of action is NMDA. So, NMDA receptor, N-methyl D-aspartate. N-methyl D-aspartate antagonist. Antagonist primarily, right? It is primarily acting on this receptor. It binds to the inhibitory interneuron in cortex and limbic system and hippocampus. So, when it binds to these inhibitory neurons, what happened? To the NMDA site. So, what happened? The NMDA receptor present involved, it gets antagonized. So, NMDA site, it binds and stop or antagonize it. Antagonize it. You know, NMDA receptor, it is present on most of the spinal neurons involved in nociception, right? It is involved in very much in nociception, like primary nociceptors of spinal dorsal horn, etc. So, when this receptor is antagonized, we get a very good analgesic effect. So, primarily it acts as NMD, N-methyl D-aspartate antagonist. Now, apart from this, it can also act on some other receptors, like it can also act on opioid receptor, it can also act on noradrenergic receptor, and it can also act on cholinergic receptor, right? Ketamine can act on opioid receptor on all mu, kappa and delta receptor, right? But its pain analgesic effect is not by the opioid receptor. It is through this NMDA antagonist effect primarily. You know, the pain activation from thalamus to insula to cingulate and ultimately to prefrontal cortex, this pathway, the pain pathway that is from thalamus to insula to cingulate and ultimately to the cortex, this is inhibited by ketamine, right? It inhibits it, and it also blocks the signal of pain involved in spino-reticular pathway, right? It also blocks the signal of spino-reticular pathway and medial thalamic nuclei and medial reticular formation, right? These are important path relays in nociceptive transmission, pain transmission between spinal and supraspinal level. All these are blocked. So, by multiple mechanism, it blocks the pain pathway, primarily through attaching to N-methyl D-aspartate site and antagonizing the effect of N-methyl D-aspartate receptor, that is, it causes hyperpolarization and prolonged opening of the channel and antagonizes the effect. So, primarily by this effect, and by NMDA attachment receptor site at multiple site, it can also produce a very good nociception. Plus, it can also bind to the opioid receptor, it can also bind to the noradrenergic receptor, right? And it can also bind to the cholinergic receptor. Now, one more thing I want to tell you, that the pain relief produced by ketamine, the analgesia produced by ketamine is by two mechanisms. One is by preventing hyperalgesia, by inhibiting the monoaminergic pain pathways. Analgesia produced by ketamine is to prevent hyperalgesia by inhibiting descending monoaminergic pathway, monoaminergic pain pathway, right? And it also provides analgesia through NMDA pathway, okay? Plus, I told you it acts on noradrenergic receptor. Actually, ketamine stimulates, its noradrenergic action is by two ways. Number one, it stimulates CNS noradrenergic neurons and also inhibits uptake of your catecholamines, right, from the blood. Uptake of catecholamines also inhibits uptake of catecholamine. So it stimulates the CNS noradrenergic neurons and also inhibits uptake of catecholamine. So what happens? A hyperadrenergic state is produced. Hyperadrenergic state. In this state, the norepinephrine, dopamine and serotonin level of blood increases, right? All these of blood increases. Got it? So this is its mode of action through multiple receptors. Now, because what is the effect of ketamine on different organ system? Since it is hyperadrenergic state, it produces a hyperadrenergic state. It has a typical effect on different organ system. On CNS, it increases cerebral metabolic oxygen requirement, okay. So whenever cerebral metabolic oxygen requirement increases, cerebral blood flow would increase. So cerebral blood flow increases. Then it increases intracranial pressure. It increases EEG activity, but this increase in EEG activity does not extend to cortex, so it does not precipitate epilepsy. Increases EEG activity, okay, but unlikely to cause seizure. So it does not precipitate seizure at all, okay. And in spite of increasing CMRO2, in spite of increasing cerebral blood flow and EEG activity, it is cerebroprotective. Cerebroprotective by NMDA antagonist effect. So it is cerebroprotective by NMDA antagonist effect. Okay. Okay. Then on cardiovascular system, it produces hyperadrenergic effect. So whenever there is hyperadrenergic effect, what will happen? Serum catecholamine level would increase and blood pressure would increase, heart rate would increase, systemic vascular resistance would increase, right? And this would lead, this would increase, these are sympathomimetic effect. These are sympathomimetic effect, okay? Sympathomimetic effect, okay? So it causes sympathomimetic effect in normal people, okay? But in case of chronic illness, this catecholamine level of the blood gets depleted. So, but in case of catecholamine depleted state, which happens in chronic illness. In catecholamine depleted state, it produces myocardial depression. It causes myocardial depression. So, you know, in pure form, it causes myocardial depression. But being a sympathomimetic, normally we all have a normal catecholamine store. It increases BP, heart rate and SVR. See, since it increases blood pressure, heart rate and SVR, it is a very good agent for induction of anesthesia in shock because it is increasing all this. So, it is very good for shock patient. And acute shock, the catecholamine is still intact. But in case of catecholamine depleted state, that is in chronic illness, this would not be a good agent to use because it causes myocardial depression. So basically it's a myocardial depressant. Just because of hyperadrenergic effect, it produces a increase in blood pressure, heart rate, etc. Because it increases blood pressure, heart rate and all, it is not a very suitable agent for cardiac patients, especially a patient with ischemic heart disease, right? So, not a suitable agent, not a suitable agent in ischemic heart disease, remember this, okay? Okay, now respiratory system. What is the effect on respiratory system? Some important differences from other IV anesthetic agent. It is less respiratory depressant compared to propofol and thiopentone, less respiratory depressant. Then it maintains respiratory drive, right? It is less respiratory depression, maintains respiratory drive. That does not mean that patient's airway should not be secured under ketamine anesthesia. See, patient airway requires to be secured because patient is unconscious, and unconscious patient can aspirate. So, though little less effect on respiration, but it doesn't mean it has no effect. In a more dose, it will cause respiratory depression and blunting of hypoxic hypercapnic drive, right? But initial small doses, it does not affect respiration much. Then it's a very good bronchodilator, wonderful bronchodilator, okay? And it increases salivation. It increases salivation. So, it can cause laryngospasm when we are using it for induction. So, we always pre-medicate our patient with glycopyrrolate before giving ketamine. So, pre-medication with glycopyrrolate would be helpful. Glycopyrrolate is helpful, okay, for respiratory effect. Now, liver and kidney, no effect. Hepatic and renal, no untoward effect, only it is metabolized by liver and metabolic byproduct is excreted through kidney, nothing else. Now, coming on clinical use, mostly it is used for anesthesia. Number one, in low dose we use it for dissociative anesthesia, something called dissociative anesthesia. What is this dissociative anesthesia? It is an unconscious, patient is unconscious like state, but eyes are open, patient breathing on their own, maintaining the spontaneous respiration, but in this state, patient would not react to any painful stimulus, okay? So, patient unconscious, but eyes are open, conscious, but eyes are open, okay? They maintain their spontaneous respiration and maintain spontaneous respiration, okay? Do not react to painful or noxious stimuli. Do not react to painful or noxious stimuli, okay? Now, second, so this was for dissociative anesthesia. The dose is less than induction dose, and for very commonly for painful procedures like wound dressing, burn dressing, we use ketamine for dissociative anesthesia dose, okay? Now, second is for induction of general anesthesia. Induction dose, IV induction dose, 0.5 to 2 milligram per kg body weight. Effect, I already told you, comes in 30 to 60 seconds. If I am using IM dose, if I am using IM dose, then the effect is, the dose is 4 to 6 milligram per kg body weight, right? And effect is little delayed. Now remember, since it increases blood pressure, increases heart rate, it is best agent for induction in shock, agent for acute shock patient, right? It's best for acute shock. Since it is causing increase in blood pressure and heart rate, this is unsuitable for cardiac patient, and it is unsuitable for normal patient also, and also for normal patients, because we don't want our blood pressure and heart rate of our patient to increase. It can increase blood pressure and heart rate to great extent. Okay, then we can use it for sedation. It's a very good sedative. Sedation in, let's say, for emergency procedures, for emergency procedures in emergency departments, particularly where let's say fracture, putting cast on the fracture, these kind of small procedures under sedation of ketamine can very easily be done, because respiration to some extent is maintained by the ketamine. Then analgesia, it can produce analgesia. So it is used for acute post-op pain, for treatment of acute post-operative pain, as preemptive, for preemptive analgesia, because it prevents hyperalgesia, right? And for post-op also, post-operative analgesia also, for preemptive and post-operative analgesia, both. So before starting the surgery, we can also give for preemptive and post-op also. And it is also very useful for chronic pain, right? It has been used in CRPS, chronic regional pain syndrome. So it is being used in chronic regional pain syndrome, right? To prevent hyperalgesia to happen. Okay, then it is nowadays its role as antidepressant. Ketamine has shown a very good role in as an antidepressant. Okay, but action is for short duration, but it has shown a very promising effect. So these are the uses of ketamine. Now, very important side effect of ketamine. So one of the most important side effect of ketamine is emergence delirium. What is this emergence delirium? In post-operative period, patient after ketamine anesthesia may be associated with visual, auditory, proprioceptive and confusional illusions, right? So this all will make the person delirious. Some very vivid dreaming, etc. may be present in the patient. And there's a possibility of a transient cortical blindness also. So cortical blindness may be associated, may be present. But everything is self-limiting. Disappears in few hours. Right? So what is the mechanism? Of this? Mechanism of this is because of ketamine induced. Ketamine induces depression of inferior colliculus and medial geniculate nucleus, of inferior colliculus and medial geniculate nucleus, right? The incidence of this emergence delirium, incidence is 5% to 30%, and increased incidence has been seen in increased incidence in more than 15 years of age if we give ketamine. I mean, it is less in children, more in adult, more in female compared to male, more on high dose, and more in person with personality disorders, psychiatric issues. So, persons with personality disorder, right? Personality disorder. So these are the few patients in which ketamine we can be associated with emergence delirium. Okay. Then prevention or treatment. Prevention, treatment, same, benzodiazepine. So prevention and treatment is same, benzodiazepine. Okay. So this is the most important complication of ketamine emergence delirium. So ketamine can be associated with other complication which we have already discussed. I would just tabulate it. It is associated with increased blood pressure, increased heart rate. It is associated with increased intracranial pressure. It is associated with increased intraocular pressure because it is sympathomimetic drug. It can also increase the gastric pressure, okay, because it is sympathomimetic drug, right? These pressures can be increased, right? Now, ketamine increases secretions in patient. This is also a problem with ketamine use. Ketamine can cause post-op nausea, vomiting, post-operative nausea and vomiting, right? So these are the side effects of ketamine. Mostly ketamine is used for induction in shock patient, and the role of ketamine as an analgesic is evolving very fast, both for acute and chronic pain, and as an antidepressant also it's evolving, it's in the evolving phase. So ketamine has a multiple roles. Okay, so this is all about ketamine. Now next group of drug which I will discuss with you is benzodiazepine. In benzodiazepine, for anesthesia purpose, 3 drugs are most important: midazolam, diazepam, and lorazepam. Okay, midazolam, diazepam and lorazepam. These 3 are the most important, like benzodiazepine. It's a big group, but these 3 drugs mostly has multiple role during anesthesia. So what is the role of benzodiazepine during anesthesia? The role is multiple. It can be used as anxiolytic agent, anxiolysis, right? It can be used for sedation, amnesia, hypnosis. It can be used for muscle relaxation. Provides a very good muscle relaxation. But this muscle relaxation happens at a very high dose, happens at a supra high dose, right? Then it has anticonvulsant role. Benzodiazepine are very good anticonvulsant role, anticonvulsants. Okay. This is a safe group of drug. Benzodiazepine, they are a safe group of drug, and with midazolam, the safety profile has even improved. Why it is safe group of drug? Because side effects are less associated with it, and it has a specific antidote in the name of flumazenil. So they have a specific antidote in the name of flumazenil, right? Okay. Now let us discuss pharmacokinetic of our midazolam, diazepam and your lorazepam. I will just compare and contrast them. Then only it would be easy for us to remember. Okay. So let us see the pharmacokinetic. Now midazolam. Midazolam, the induction dose is 0.1 to 0.3 milligram per kg body weight, right? Diazepam 0.3 to 0.6 milligram per kg body weight. Lorazepam 0.03 to 0.1. So lorazepam is definitely most potent. Okay, lorazepam is most potent. Then duration of action. Midazolam 15 to 20 minutes, right? Diazepam 15 to 30 minutes. Lorazepam 60 to 120 minutes. So your midazolam is shortest acting, shortest duration, and lorazepam has longest duration. Half-life of midazolam is 7 to 15 minutes, diazepam 10 to 15 minutes, and lorazepam, let's say 3 to 10 hours. Now protein binding, all have a very high protein binding. Volume of distribution, your midazolam 1 to 3.1 ml per kg body weight, diazepam 0.7 to 1.7, and lorazepam 0.8 to 1.3. Clearance is also more of midazolam, so it has a faster clearance. Elimination half-life is short. So if I see this table, what information we get? The information which I get is midazolam, short duration, right? Short duration, faster elimination from body. So short duration and faster elimination from body. So this makes midazolam a better drug over other two agents, diazepam and lorazepam, during anesthesia practice. Okay. Now next important thing which we need to know about them is their duration of action, right? Their duration of action and metabolite. But before that, this lorazepam and diazepam, they are not soluble in water, not soluble in water. They are not soluble in water. So propylene glycol is mixed with it. Propylene glycol is mixed with it, and this can cause pain. So they can cause pain on injection. Pain on injection. Okay. Your midazolam is water soluble, but can cause mild local tissue irritation. Mild local tissue irritation. Okay. Okay. Now coming on the duration of action, midazolam shortest. Midazolam has shortest duration of action. Okay. Lorazepam has longest. Diazepam also has long duration. Now all three are metabolized in liver. So all three are metabolized in liver, right? So this also liver, this also liver, and this also liver. And the hepatic clearance of midazolam is fastest clearance compared to these two agents, right? So same thing which I told you in this table also. Shortest duration, fastest elimination from body, right, of midazolam pharmacokinetics compared to diazepam and lorazepam. Okay. Now let us talk about pharmacodynamic. What is the mode of action? Mode of action of benzodiazepine. They again act on GABA A receptor. So GABA A receptor, they have a specific benzodiazepine binding site, has a benzodiazepine binding site. it binds and increases GABA A receptor and chloride channel interaction, resulting in prolonged opening of the chloride channel and hyperpolarization, resulting in prolonged opening and hyperpolarization, and this results in neural inhibition. Now, as compared to other drugs, benzodiazepine can have sealing effect. So, they can produce sealing effect. And their effect on CNS is also dose dependent. It is dose dependent. If the dose, let's say, decreased to 30, if we, whatever dose we give, it is occupying only 30 to 40% of the benzodiazepine site on GABA A channel, then it will only produce sedation. And if it is occupying only 20%, then it will only produce anxiolysis. So, dose dependent action, 30 to 40%, 50% receptor occupancy will cause sedation, and 20% will cause anxiolysis. So, according that, we can increase the dose according to our requirement. Anxiolytic dose is less, and definitely the sedation dose will be more. The effect is dose dependent, and if you increase more the dose, the patient will become unconscious. More the occupancy of the receptor, patient will become unconscious. Okay. Now, effect on central nervous system. Effect on central nervous system more or less same like other IV anesthetic agent. Decrease CMRO2, decreased cerebral blood flow, decrease intracranial pressure. Till here same. But this is different from other IV anesthetic agent. Since it has a sealing effect, there is no burst suppression seen with benzodiazepine. So, no burst suppression. No burst suppression seen. No isoelectric EEG. No isoelectric EEG. Right? Neuroprotectant effect is limited. So, neuroprotective effect is limited, not very neuroprotective as compared to other IV anesthetic agent. Anticonvulsant, it has anticonvulsant effect on central nervous system. Anticonvulsant, so it is used for management of seizure. One of the first line of drug for managing seizure. And muscle relaxant effect through CNS effect by decreasing the tone. Muscle relaxant effect. So, these are the effect on central nervous system. Now, let us see the effect on cardiovascular system of your benzodiazepine. So, benzodiazepine is less cardiovascular unstable, but decreases systemic vascular resistance. So, decreases blood pressure and increases heart rate. So, simple effect on cardiovascular system. Respiratory system, less respiratory depressant compared to other IV anesthetic agent like ketamine. Less respiratory depressant. Right? Less respiratory depressant, but can depress respiratory center at a higher dose. Respiratory center at higher dose. Okay, can depress respiratory center at higher dose, and can also blunt hypoxic and hypercapnic drive. Can blunt hypoxic and hypercapnic drive. Okay, this is the respiratory effect. Now let us see uses and side effects. But before the uses, let us see the side effects. Side effects, what it can produce? It can produce hypotension, right? But limited side effects, limited side effects, not much side effects, right? Then uses, we mostly used in anesthesia for pre-medication and for anxiolysis. So pre-medication, anxiolytic effect. Okay, the dose is 0.02 to 0.04 milligram per kg IV or IM. This is the pre-medication for anxiolytic effect. And if I am giving oral, then 0.5 milligram per kg body weight oral. So for pre-medication, we always give, let's say if I am giving oral, we have to give 30 minutes prior for the effect. Okay, its effect comes in 30 minutes. For induction dose 0.1 to 0.2 milligram per kg body weight. Okay, IV. And if I am using it for maintenance of general anesthesia, then the dose is 0.25 to 1 microgram per kg per minute infusion. Got it? So we use it for pre-medication mostly. We can use it for induction and maintenance in following doses. Okay. If overdose happens, side effect is limited, and plus one more benefit is that if side effect comes, if overdose happen, if prolonged respiratory depression is seen, we have an antidote in the name of flumazenil. So flumazenil. What is flumazenil? It is 1,4-imidazobenzodiazepine, right? It is specific antidote for benzodiazepine. So this is the antidote. What is the dose in which we give this antidote? 0.2 milligram IV. We can repeat after 1 minute to maximum of 3 milligram, right? To maximum of 3 milligram. This is the dose of flumazenil. The pharmacokinetic of flumazenil and pharmacokinetic of your benzodiazepine matches. This is also metabolized by liver. The effect is short-lived, right? So effect lasts for 30 to 60 minutes only. So you need to repeat the dose if the condition gets prolonged. Metabolized by liver. So benzodiazepine has a specific antidote which makes it quite safer drug. But use of benzodiazepine nowadays in anesthesia is predominantly as pre-medication for anxiolytic effect. Anxiolytic effect of midazolam is wonderful, of your benzodiazepine is wonderful, and it is so good dose dependent effect on CNS. So depending upon the effect we want, let's say we tighten our dose accordingly, right? So we try for a less receptor occupancy for anxiolytic effect, and this is the predominant role which today benzodiazepine is playing in anesthesia. Okay. Now the next group of drug which I will discuss with you is your barbiturates. Barbiturates nowadays are becoming obsolete. It is being completely replaced by propofol. But let's say it's worth mentioning since it has a strong historical background. It came in clinical practice in 1934. Which drug came? Thiopentone. thiopentone. So thiopentone came in 1934. Okay, this was the first IV anesthetic agent, IV anesthetic. And with thiopentone, your balanced anesthesia technique started. Okay, now let us talk about what are the barbiturates which we use in anesthesia practice. Now, two type of barbiturates major class we use in anesthesia practice, thio and oxybarbiturate. So, two major classes of barbiturate, oxybarbiturate and thiobarbiturate. Thiobarbiturate. In oxybarbiturate, the important drug is methotrexate. Now, this in oxybarbiturate, right, pyrimidine ring which the barbiturate has, it has oxygen at position 2. So, it has oxygen at position 2. Thiobarbiturate, it has sulfur at position 2. And there are two thiobarbiturates, thiopentone and thiamial. The concentration in which these drugs are used for anesthesia. Thiopentone, 2.5% concentration is used for anesthesia. Thiamial, 2%. Methotrexate, 1%. Now, most of the barbiturates, they are highly alkaline. Highly alkaline powder. And they have to be reconstituted. Since they are highly alkaline, we either use normal saline or distilled water to prepare it. If we will use acidic solution, precipitate will form and they cannot be used for anesthesia intravenously. So, if acidic solution is used, it can cause precipitation of drug, right? So, we always prepare it with normal saline or distilled water. And once it is prepared, we can store it. We can store it for 1 week to 2 weeks for thiopentone, the shelf life, and 6 weeks for methotrexate. Okay. Now, thiopentone is intravenously not painful, but methotrexate is painful intravenously. So, IV injection of thiopentone, not painful, but if it gets extravasated in outside the vein, then it can cause pain. But IV injection of methotrexate is painful. Methotrexate is painful. Okay. Now, let us talk about the pharmacokinetic. Okay. Pharmacokinetic. Let us say I gave the induction dose of thiopentone. Induction dose. It has a very fast effect. It will go to the vessel-rich organs, and that is central nervous system, effect will happen. Then rapid redistribution to other tissues. Rapid redistribution to other compartments, So, what will happen? Termination of the effect. The patient will regain the consciousness. Termination of effect will happen. Patient will regain the consciousness. But if we give continuous infusion for maintenance right? So continuous infusion in blood. So what will happen? It will go to the vessel rich organ, that is CNS effect, and it will also go to other vessel rich organs like CVS and all. So side effects, right? Then it will also go to peripheral tissues from blood, peripheral tissues. Here it will accumulation, and slow metabolism will also happen, slow elimination. The slow elimination is by liver, hepatic oxidation, by the process of oxidation. So water soluble metabolite is produced, water soluble, which is excreted in urine and bile. Okay. So for maintenance, this continuous infusion, it is getting accumulated in the peripheral tissue. It is highly lipid soluble, and its let's say clearance is very slow, and very slow clearance rate. You know, its context sensitivity half-life is 12 hours after infusion, and its elimination rate is only 3 ml per kg per minute. So there is always a delayed recovery if we use thiopentone for maintenance. So prolonged context sensitivity half-life, so delayed recovery. So that is why thiopentone is not a good drug for maintenance of anesthesia. We talked about propofol as the first drug in IV anesthetic agent, and I told you propofol is a wonderful drug. Why? Even if you give a prolonged infusion of propofol for, let's say, 12 hours or 8 hours or something like that, what will happen? It will go out of the body within 2 hours. Metabolism is pretty quick. Elimination is pretty quick, does not accumulate in the body. But this drug is getting accumulated in the body. So mostly thiopentone has been replaced by propofol. But there is one good thing of thiopentone, its cerebroprotective effect, which has still kept some role of thiopentone in few surgeries where cerebral protection is required. So what is the effect on CNS and how does it provide a cerebroprotection? So on CNS, like, first of all, what is the mode of action? Mode of action. Where does it act? GABA inhibitory pathway. GABA inhibitory pathway. Both cortical and it potentiates the GABA inhibitory pathway of cortical and brain stem. Right? This potentiation of GABA inhibitory pathway cause loss of consciousness. Loss of consciousness. But apart from GABA, it can also act on NMDA and cholinergic receptor also. So, can also act on NMDA and acetylcholine receptor. Acetylcholine receptor, right? So, by acting on NMDA, it inhibits the excitatory pathway and it promotes the inhibitory pathway. So, it produces loss of consciousness. Okay. Now, let us see how does it affect central nervous system. So, like any other IV anesthetic agent, it is putting the patient in sleep mode. So, it would decrease the cerebral metabolic oxygen requirement in dose dependent manner. More the dose, more the CMRO2 is reduced. So, decrease CMRO2 in dose dependent manner. Dose dependent manner. EEG changes from beta to alpha to theta to delta causes burst suppression, which is very important for cerebroprotective effect. Burst suppression means they can make a silent EEG. Burst suppression. Isoelectric EEG can be produced. Isoelectric EEG can be produced. Okay. It maintains cerebral perfusion pressure. Compared to propofol, it produces less decrease in blood pressure. So, maintains cerebral perfusion pressure. It maintains cerebral perfusion pressure. Okay. So, this is the effect on central nervous system, all good effect. Now, apart from these good effect which it produces on CNS, it produces some additional cerebroprotective effect. So, it's neuroprotective role or cerebroprotective role. Now, some things I have already wrote. Decrease CMRO2. This thiopentone decreases CMRO2 maximally, right, by 50%. Then anticonvulsant. Then it produces something called reverse Steele phenomena. Reverse Steele phenomena. In this, from non-ischemic perfusion goes to ischemic area. So, improves perfusion of ischemic part of the brain. So, improve the perfusion of ischemic part. Then it is free radical scavenger. Free radical scavenger. Right? Then it attenuates the excitatory neurotransmitter release, decreases the excitatory neurotransmitter release. This all leads to membrane stabilization. Membrane stabilization. So, this causes neuroprotective. These are the causes of neuroprotective role. But it is more useful for neuroprotection in focal cerebral ischemia. More useful for focal cerebral ischemia rather than for global cerebral ischemia. Right? Okay. Now, this is anticonvulsant, but one thing different is in methohexatone. Methohexatone is proconvulsant. So, methohexatone is proconvulsant. That's why it has a role in ECT, for ECT, because during ECT, as already I told you previously also, for ECT we want the proconvulsant IV anesthetic agent, because after giving ECT we have to see the seizure to see whether the ECT was successful or not. So, most of the IV anesthetic agents are anticonvulsant, so they will suppress that seizure. Methohexatone is proconvulsant, so it will not suppress that seizure. So, it has a role as in ECT. Okay. Now, let us see the effect on central nervous system, cardiovascular system. We are done with central nervous system. Okay. It decreases systemic vascular resistance. Decreases systemic vascular resistance. So, mean arterial pressure decreases. Okay. Then, because of decrease in systemic vascular resistance, vasodilatation happen. So, peripheral pooling of blood in lower limbs and all. So, this will decrease the venous return and cardiac output, both will decrease, cardiac output. Okay. Then it has a negative inotropic effect on heart, negative inotropic effect. On heart rate, it increases by 10 to 15%. So, heart rate, it increases by 10 to 15% by reflex sympathetic tachycardia. It does not blunt reflex sympathetic tachycardia like propofol. So, here it is different from propofol, different from cardiovascular instability of propofol, from propofol. Propofol causes bradycardia. Thiopentone does not inhibit the reflex sympathetic tachycardia. So, it causes tachycardia. Now, respiratory system. For respiratory system, it causes respiratory depression like any other IV anesthetic agent. Respiratory depression causes respiratory depression. Okay. It blunts hypoxic and hypercapnic drive. So, blunts hypoxic and hypercapnic drive, right? Then it is a bronchoconstrictor. It can cause bronchospasm and laryngospasm. Till now, we haven't discussed any anesthetic agent which is a bronchoconstrictor. This is a bronchoconstrictor. So, in patients with reactive airway, it is preferably not to be used. So, bronchospasm and laryngospasm, especially in patients with hyperreactive airway. Hyperreactive airway. Okay. So, bronchial asthma patient, hyperreactive airway, avoid thiopentone. Coming on uses. For anesthesia, it has become obsolete. If at all it is used, it is only used for induction. So, only for induction. In United States, the production has been stopped. In India also, slowly it is going away. So, induction dose 2.5 to 5 milligram per kg body weight, right, of thiopentone. And onset 15 to 30 seconds, very fast onset, right? Onset is very fast. This is the dose of thiopentone. Thiopentone. And if you have methohexytone, the dose is methohexytone. The dose is 1 to 2 milligram per kg body weight. Onset, again same, 10 to 30 seconds. Okay. So, induction. For anesthesia, mostly induction. Another use during anesthesia is cerebral protection for the surgeries in which we are, let's say, we are thinking that there would be a decrease in renal, perfusion of the brain. There is a risk of hypoxia. Thiopentone infusion, etc. are given to the patient to decrease any, let's say, ischemic injury to the brain. So, neuroprotection. Neuroprotection in patient with risk of focal ischemia. In patients with risk of focal ischemia, right? And then it is used for narcoanalysis also. Narcoanalysis. It is the drug of choice for narcoanalysis. Drug of choice for narcoanalysis. Okay. Now coming on side effects. Side effects of thiopentone. First, it is cardiovascular unstable. So, decreases blood pressure, right? Increases heart rate. It decreases blood pressure. Avoid in shock patient. It as induction agent. Then it can precipitate porphyria. It is enzyme inducers, right? So, in porphyria, it is contraindicated. Contraindicated in porphyria. Okay, because it is enzyme inducer. Then it can cause bronchospasm. So avoid in patient with hyperreactive airway. Hyperreactive airway, like your bronchospasm, etc. It can precipitate bronchospasm. So these are the side effects and contraindication of using thiopentone. Today, the use of thiopentone for anesthesia is getting obsolete. If at all it is used only for induction, it has been completely replaced by propofol, right? So this is all about our IV anesthetic agent which we use for induction and maintenance of general anesthesia. Thank you.